Dr. Tomeo, thank you for joining us here on MD Newsline. Would you please introduce yourself to our audience?
So, my name is Michael Tomeo. I'm a board certified dermatologist. I've been practicing for many years. I've had a clinical practice for many years. I'm actually now doing some research. And interestingly, one of the projects that we're working on has to do with chronic urticaria.
Wow, yeah, and that's what we're here to talk about, chronic hives, urticaria, as you called it. Could you start by giving us just a brief definition of chronic urticaria and how it differs from other forms of urticaria?
So, chronic urticaria, by definition, is hives, usually on a daily basis, that last at least 6 weeks. So, if you're experiencing hives on a daily basis or very frequently, and that period of time has exceeded 6 weeks, we consider that chronic urticaria.
And from a clinical perspective, how common is chronic urticaria in practice, and are we seeing changes in incidence or patient demographics?
Um, Not necessarily in demographics. It seems like the highest incidence is in Asians for some reason, interestingly. But I would say the incidence it affects about 1% of the population. So that, in America, we're talking about 3 million people essentially. It comes and goes, and the population do change in terms of who gets affected. But generally, it's also a female predominant disease, probably 70 to 30 in that ratio, 70 to 30.
Interestingly enough, we always have this conversation about how females are more affected by autoimmune
Correct.
things.
That's right.
And this is something that has autoimmune implications, obviously. So, what are some of the current insights into immunologic or non immunologic mechanisms driving urticaria?
Well, when we talk about urticaria, we can also divide it into what's called chronic spontaneous urticaria, which is CSU, and that composes a lot of the urticaria that we see in our office. And that can be fractionated in two ways also. There's an autoallergy form, which is IgE driven, and there's the other form, which is more immunologic or autoimmune, and that's driven by IgG.
Mhm.
So those are really the two main forms that we see in CSU.
So let's talk a little bit about what that means for an average person. When you say chronic spontaneous
Right.
versus chronic, like what does an average patient, how do they experience that in their body and what's driving it for them?
Well, they don't know what's causing it, and oftentimes we can't really define what's causing it. We know there's an immune mechanism at work, but we don't know what triggers it, so to speak. So we try to determine what's causing the urticaria. If it's acute, oftentimes that does resolve on its own. But if it's a chronic urticaria, there's probably some sort of immune dysfunction that's resulting in the urticaria. So what we do is we do some testing, but most importantly, we do a history and we try to determine if there's been any exposures or if there's been any changes in patient's medical situation. But we can do some testing to determine, maybe to fractionate, which type of urticaria it is.
Mhm. So when you say spontaneous or chronic spontaneous, those words seem to go against each other, right? So what does that mean? How do patients experience the chronic spontaneous combination?
Well, we actually used to call it a chronic idiopathic urticaria. Maybe that's a better term because oftentimes we don't know what the cause is. Even though we understand the immunology, so to speak, we don't know what the trigger is and we don't know why people are developing it spontaneously.
Gotcha. So, can you describe the role of autoimmunity, specifically IgG autoantibodies
Mhm.
against FC receptors in the
Yes.
pathogenesis?
When we talk about urticaria, the main cell that we're talking about is the mast cell. So the mast cell has an FC receptor, as do other cells. But when that FC receptor is stimulated by IgE, for instance, or IgG, the end result is it releases vasoactive materials such as histamine. And that's what causes the start of the inflammatory process, the immune process.
Interesting. Mast cell disease and mast cell related issues, it feels like they've become more prevalent in conversations around health and immunity and things like that. Has there been any changes just from your experience and people who are experiencing that, or is it that it's just getting diagnosed more accurately and more common?
I think we've learned a lot more about the immune system and the mast cell in particular. The mast cell is a very interesting cell because it's also a cell that regulates what we call innate immunity and also acquired immunity. So it really is a cross between those two, and it's also a cross between the nervous system. It's a neuroimmune cell and the immune system. So it's a very fascinating cell, which we're learning a lot more about.
When I think about this, anything dealing with immunity, anything dealing with, neurology, the first thing that comes to my mind is like, what is happening in stress and mental health and the environment,
Hmm.
dietary,
That's right.
whatever is exacerbating that. Because when I see these conversations happening, I'm starting to see the body being talked about as more of like a whole ecosystem, right? So even when we talk about immune issues, right, there's papers that have come out that say like, inflammatory markers can migrate across cell membranes and things like that, maybe triggering inflammation in different parts of the body. And so
Right.
this idea of the body as a whole and leaning more towards maybe even translational medicine when we gather this information, I'm curious to know just when it comes to chronic hives, are there any insights on environmental, dietary, psychological things that might make them worse or even trigger them? Like, have you found patients saying, like, I went through this health event and then this happened, or, you know?
Well, as we know, stress can cause a lot of diseases, and it certainly can affect either directly or indirectly the mast cell, and that releases histamine. So, yes, stress can definitely be a releaser of these vasoactive substances that causes the wheals or the urticaria that we see. So, yes, stress is one thing. Diet, of course, is a big effect. As we know, there's a relationship between the gut and also the lungs and also the skin. So and the brain. So we have all these organ systems interacting. And so you can see how one organ system can affect another organ system.
Are there any comorbidities with things like this? One thing that comes to mind for me is people who are prone to things like oxidative stress, people who maybe are like have like neurodivergence, or they're, you hear people who they've got the atopic triad, right? Eczema, atopic dermatitis, and asthma often go together. These are inflammatory things, right? So then I'm wondering, are there any other things that often come along with chronic hives?
Well, what we're most concerned about is angioedema, which is a more serious form, a deeper form, if you will, of urticaria, and of course anaphylaxis, which is a state where the body basically turns off. It turns down because there's a hypersensitivity that's affecting all the cells. So the mast cells all throughout the body start releasing histamine, and that's really a life-threatening situation.
Mm-hmm.
So we hope that we always hope that it never devolves into that situation, but anaphylaxis is a real thing.
When someone has something like mast cell, chronic hives, and it goes undiagnosed for a long time, right? So maybe they're just like, this is just how my body is. People get used to living with certain things, even though um, if they don't go into something as extreme as anaphylaxis, what's the impact of chronic long-term mast cell activation on the rest of the body?
Well, first of all, it's a miserable existence. I mean, nobody wants to have blotches all over their body and also the itch that comes with it. It's really distressing. It affects your sleep, your ability to work and function. So it's very important to get this disease under control, this condition under control.
Does it impact eventually any of the other organs, or are there any kind of does the chronic histamine release lead to any other things that you know might not have been present before?
Well, histamine receptors are all throughout the body. They're in the GI tract. So yes, could you develop diarrhea? Could it cause bronchospasm in the lungs? Could it stimulate the brain? Certainly sensory nerves. So yes, all those are connected because all those cells in those different areas have histamine receptors.
So let's talk a little bit about diagnostics. What essential elements should a diagnostic workup include to confirm chronic spontaneous urticaria and exclude other causes?
The most important thing is the history in the physical exam, the history in particular, because you want to figure out how often the hives are presenting themselves. You also want to know how long they last. Because if a hive lasts longer than 24 hours, we also have to think about more serious conditions like vasculitis. Now, vasculitis can be related to autoimmune diseases such as lupus, for instance. So that's something that's very important to distinguish. But to better define which type of chronic urticaria, we can do some blood tests. We can look for IgE levels. If they're elevated, that points more to the autoallergy type of urticaria. If IgG levels are elevated, then we think more of the other type of disease. The most common type of spontaneous urticaria, chronic spontaneous urticaria, is the autoallergy type, and that's probably accounts for 70% of the cases that we see. So there are some diagnostic markers that we can look for in the blood. We also get an ANA if we think there might be an autoimmune function. We also do a CBC. We may check a CRP and a SED rate to see if there's inflammation in the system. Sometimes we also check thyroid antibodies because thyroid disease can also trigger urticaria.
So, how long generally does it take a patient to get an actual accurate diagnosis in this case? Because I figure with things like this, where it's like a really bad itch, people might go through a lot of problem solving on their own. They might start taking things over the counter. I'm wondering, what the distance is from, beginning to end generally that you're finding with patients that you see.
I think patients generally recognize that they have hives, they have wheals on their body. But the question is, how much is it affecting their life? And I'm sure a lot of people reach for antihistamines. We seem to know that that may be a help and probably is a help in about 40% of the cases. But once they see the dermatologist or the specialist, we ask questions like how long, how often, those type of things. How is it affecting your lifestyle? Is it itchy versus is it itchy versus painful? If it's more painful and it's a deeper type of urticaria, that's angioedema. They're all related. It's a histamine disease also, but it's a little bit more severe in terms of appearance. You'll get swelling around the eyes, around the mouth, maybe the tongue, the hands, the feet. So angioedema is really just another level of urticaria. So we try to figure out what type of urticaria it is. If it's more than 6 weeks, as I told you, it's chronic. Then we sort of define the subtype of what it is.
And when people are taking over-the-counter medication, are there any medications that might impact lab tests? Or, because I'm wondering, if a person doesn't know that they have chronic hives, like officially, and they're just like, I'm just taking Claritin or I'm taking, Allegra every whatever. I feel like that might impact their conversation with their doctor when it comes to saying this is how I feel, or kind of gauging the severity. But I'm also wondering if that impacts lab tests at all.
Not really, because if we were to measure histamine, for instance, the histamine is still there. It's getting blocked at the cellular level by the receptor. So you still have the normal or the abnormal histamine levels, if that's something you want to measure. But all the other lab tests are really not affected much by taking antihistamine, for instance.
Interesting. So could you outline a little bit your stepwise approach to pharmacologic therapy in line with current guidelines?
So we always try antihistamines. That's always our first attempt. And then we move up the antihistamine to about 4x, 4 times the normal dosing. And we find that maybe in 40% or maybe a little more, if we're lucky, we're controlling the disease. But oftentimes we need to go to another level of care. And that's when we start thinking about things like Zollar, which is an IgE. Basically, it's an antibody against IgE. So it's actually reducing IgE levels. And that's very important in the autoallergy type 1 response. So that's one way of figuring out, it's type 1. We can treat that with a drug like Zollar. There are new drugs coming out that are even better at binding the IgE, and we'll see those coming out in the near future.
How do you tailor antihistamine use, particularly updosing versus combining agents for refractory cases?
Sometimes not only do we increase the H1s, the non-sedating antihistamines such as Zyrtec or Claritin or Allegra. Those are the common ones that we see. Sometimes we'll add what's called an H2 blocker. So there are actually four receptors of H1, H2, H3, H4. We tend to try to block H1 and H2 because we find that that's the most important in terms of reducing this inflammatory response.
Mm-hmm. And do you find with antihistamines, even with things like Claritin, the thought of developing like a resistance to the treatment comes to mind? Is that something that patients often have to worry about, and how do you deal with that?
It's not necessarily resistance. It's just that they're not totally effective. Mm-hmm. They tend to work to some degree, in some people better than others, but it really is variable. So you don't know until you try. Mm-hmm. And like I said, you push the dose of the H1 blockers, the non-sedating blockers, and then you add H2, and then you may go to a drug like Zollar. And then we can talk about other drugs that are coming out also that are helpful.
Yeah, I definitely want to get to those other ones too. What are your strategies though for managing patients who don't respond to high dose antihistamines? Is that common, for instance, and is there a particular group or kind of presentation that's impacted more by?
It's not a predictable response. So basically you have to try it. You always try that antihistamine approach. Unless you knew for sure that it was a type 2B autoimmune type of urticaria, which you wouldn't necessarily know. But basically, you always push the antihistamine dosing as much as you can, and then you need to go to other levels of care.
Mm. Could you discuss the current and emerging roles of biologic therapies, like some of the ones that you've discussed, and just kind of go into what your opinions are on some of those
Absolutely.
approaches?
So our approach was what we called downstream blockage. We were blocking at the H1 level, at the cellular level, the effects of histamine. We were trying to block that effect. Now we're trying to do up. We're going upstream, so to speak. So we're blocking IgE, that's Zolar. We're also finding that there are enzymes and that form cascades that actually, if we can stop those processes, the mast cells are not allowed to degranulate and send out the histamine. So if we can block intracellularly or at the receptor level, that's a better way to treat this disease.
Mm.
So what we found is that there's something called Burton tyrosine kinase, and if we can block that enzyme, we find that there is a reduction in the degranulation of the mast cell. So histamine's not released. So we find that's a very effective way of doing it. There's also another receptor that we're targeting. It's called a KIT receptor. It's on the cell, it's on the mast cell. And if we can block that at that level, the mast cells don't survive as well. And we're finding that we're reducing mast cell uh, degradation. I mean, not degradation, but release of histamine as a result, because there are less mast cells and they're less effective.
When you consider cyclosporin or other immunomodulators, how do you monitor safety in those scenarios?
Well, truthfully, I stay away from cyclosporin. It was a therapy that we used in the past, but now that we have these newer drugs that are available to us, there's really no need to use cyclosporin. But cyclosporin is basically a general immunosuppressant. It really works on the T cells, which secondarily work on the B cells, which secondarily work on mast cells. So it's a really indirect effect. But cyclosporin can cause hypertension. It can cause abnormal hair growth. It can cause kidney disease. So it's a drug that I avoid
Hmm.
in
What are the
particular.
common side effects for either therapy route that we've discussed so far? And are there any that you consider kind of a real, um, that have real quality of life impact that you have to talk to patients about particularly?
Actually, the drugs I mentioned, like Zolar and the KIT receptor inhibitor and the BTK, they're pretty safe for what they do. We're finding there are some side effects, but they're really tolerable side effects.
Mhm. Interesting. Tell me a little bit, what are some common misconceptions that you find with patients about triggers or allergies and chronic hives, and how do you address them?
Well, triggers are things like bee stings or venom exposure, foods in some cases, or environmental exposures, air exposures if you're allergic. So, yes, there's an allergic component to all of this.
Mm.
And of course, the immune system gets stimulated as a result. So if we can define what's causing those causes of urticaria, then obviously we eliminate them.
Mm.
So it's an elimination diet, for instance, if it's a food item. But in chronic spontaneous urticaria, we find that that's more of an autoallergy or an autoimmune condition. It's not necessarily related to something external.
Mhm. How do you integrate patient-reported outcome tools like urticaria activity score into management or follow-up decisions?
I think those scores are important because you're interviewing the patient and determining how often are you getting their hives, how's it affecting your quality of life, so and how much itch do you have. It gives us a basis of how they're doing now, and how they're doing during therapy if you institute therapy. So those scores are very important, particularly in research.
Mhm. Do you see benefits from multidisciplinary care, such as dermatology allergy collaborations or psychological support for long-term outcomes?
No doubt. In fact, in the past, I would often refer to allergists if I had a patient that had a chronic urticaria where I couldn't help them, because initially I wasn't using drugs like Zolar, and they were. So that was a referral.
Mhm.
The collaboration also is that if for instance urticaria vasculitis is suspected, they're going to send the patient back to us for a skin biopsy. So there is that collaboration between us.
Mhm. What are some areas of chronic urticaria research that you're most excited about? I know that you're doing your own research. I would love to hear more about that and what you're kind of focused on and what you hope to focus on in the future.
Well, as we learn more about the mast cell and the way it works and all the different levels that happen within the cell, it's fascinating. We're finding out there are so many ways to block the histamine release. And like I said, we're trying to go upstream instead of downstream. So we're trying to abort the whole cascade of releasing histamine. So if we can stabilize the mast cell, that's the key to treatment, and we're getting better and better at that. I mentioned, looking at the KIT receptor, also the BTK enzyme. If we can block some of those things early on within the cell will not degranulate and release histamine and other vasoactive
Mhm.
materials.
Interesting. Um, how might a growing understanding? I know you mentioned mast cell biology. How about the gut skin axis? How's that reshaping future treatment from your
Well,
perspective?
you may have heard of the leaky gut syndrome.
Yeah.
Okay, so basically there's increased permeability because there's inflammation in the gut. And as a result, what's being released? Antigens. Antigens stimulate the immune system. So if we can get the gut in better shape, and we can do that through dietary manipulations, that can help the whole system. Can it help eczema? Possibly. Asthma? Possibly. Some of those diseases that are
Mm.
interrelated.
And this topic of dietary changes is always very popular. What comes to mind is the Mediterranean diet. But what
Yes.
are some of the dietary things in general? I know it might be specialized a little bit more per patient, but what are some of the general dietary things that you're finding just in your collaborations that often work?
I would say, wheat allergy, gluten sensitivity is a big one, particularly when you talk about the gut. I don't think that as humans, we became farmers and we ate a lot of wheat, but that's not how we started. And I think we probably do have a general intolerance to wheat and gluten. And gluten is a big molecule to be, processed. So that can cause a lot of gut issues. So there's something, if you certainly can cut down on your gluten, I think we'd all be healthier.
Interesting. What do you hope general practitioners and specialists take away from recent advancements in managing CSU?
For me, I've got great hope because, as I said earlier when you and I had spoken, in the past, I really had very few things to offer patients with urticaria. I offered them antihistamines. Sometimes I used steroids and not effectively. And cyclosporin was something that we had to use, we had to reach for if we were really desperate. But now we have drugs that are much more targeted and safe. So it's really an exciting time to be in medicine, and particularly with urticaria. And that goes for other diseases that we're treating also: psoriasis, atopic dermatitis, even hidradenitis.
Mhm.
We're finding that we're learning so much more about the immune system and how to regulate it. And that's what it's all about.
Wonderful. And is there anything that you want to leave patients with? I know that this is such it's a tough thing to live with. It's hard to get diagnosed sometimes. So what do you want to say to patients just about maybe advocating for themselves, understanding the disease more, just so we can work together to improve outcomes overall?
It's a great question because I wish patients were better at documenting their disease. That's important to us. If you come in and you have a diary and you can tell me when you're getting the hives, how often you're getting the hives, where they are. So all those things are important because it helps define the type of urticaria that you have. Also, your response to therapy is very critical. So keeping a diary is something that I would suggest.
Mhm.
Obviously, you want to be a good historian. You want to tell me what drugs you may be on or were on. Also, any other exposures that might be pertinent.
Mhm. And when you say exposures, you mean what exactly?
Could be airborne, could be basically through the mouth, through any mechanism to influence the body's function.
Wonderful. Anything else that you want to leave us with when you think about chronic hives in general and your hope for the field?
Well, as I said, I'm so hopeful and I'm so appreciative that we have so many new pharmaceuticals and that our understanding of the immune system keeps getting better and better, and that we can really have such great targeted therapies, which are safer than ever.
Wonderful. Well, this has been an amazing conversation, Dr. Tomeo. Thank you so much for joining us on
Thank
MD
you.
Newsline.
Sure. Thank you.